I can probably handle it. Mid.
Sounds good.
Not much.
Did you save it on the desktop?
Well, it's on the flash.
I'll just leave it there. You want to drag it on? It's up to you.
Absolutely. Even if it gets pulled out, it'll still stick there. So let's turn it off. It on?
Sorry the stuff was late. Sorry the stuff was late.
Oh, it's getting there in the end, but they're using like a slide.
That's very
Like
light.
2 slides.
It's an investment. Trouble a lot more.
Dinner wasn't going well.
Traveling? In trouble a lot more.
I mean, if it's helpful.
Tell me about it. Where are people parking these days? This is all taken up. Well, yeah, I got a street spot, but are there underground parking in that garage over there or no?
Usually not, because usually it's not full. Street, and you don't have to pay till 8.
Yeah,
So
yeah.
I think most people are parking on the street. It's not like it was a few years ago when they were doing construction all around.
Yeah,
You can't
it's
find
different.
parking. Yeah, that was bad a few years ago. But yeah, they're still doing some construction, but it's not nearly as much.
If you get here before 6:50, you can usually get on the street.
Yeah.
It's wide open.
If you go walk down, it's always open, the entire stretch.
On Westlake or?
It's one block west of Westlake. I don't know what the name of the road street is.
Oh, yeah. It's not quite yet. Fairview, no.
Yeah, it's like a,
I know what you're talking about.
smaller street, but now it's all built by the apartment, 10-hour parking lot.
Oh, no, no. You woke up and everything is bad.
That's only after. The more I look back at it, and I was like, I don't know if this is really what it was. I started to remember what the fit was. One morning.
Do you guys have a preference for sub-Q versus... Hans is all about sub-Q, right?
Yeah, I mean, I don't think they care too much as long as I get it. Obviously, the troughs and things like that with IVIG, but ultimately, they don't care really how they get it, just as long as they...
What do you guys do with the U?
We're about 50-50,
Yeah.
What I do is usually start people on IVIG and have them back in 3 or 4 months and say, what do you want to do? Give them like the high central website. So,
I mean,
it's ultimately up to them.
on the outside, I mean, kind of the reason I didn't bring it up, I won't bring it up in the talk, because there is a shit ton of there are a ton of manufacturers who come in and bother us.
Yeah.
Good morning, boss.
And I mean, like, did you realize how many different products are coming out? It's all the neurologic medications.
6.
So they're making
I think Dave works till 6. I mean, I'm there. It's just,
We're about 50-50.
we have shots. 2.5 to go.
They're like 400 products.
No.
That's good.
I really don't.
Not working. I mean, it's incredible how many options.
I know.
And no carcinogens.
What's that?
It'll be a long day.
That's been a long.
Getting used to this place.
Yes.
You were up and out? You're all over the...
Oh, yeah, I grew up in Portland.
Oh, well, there you go.
Yeah.
Younger folks.
Oh,
Yeah.
How are your tests? You guys had exams?
Yeah.
Yeah? Good.
Okay. He's hopeful. Yeah.
Well, you take those tests and you feel like you're the biggest idiot in the world, but you'll be fine.
That's the good thing about them is there's so many other idiots below you. That
You hope. I mean, that's the thing. But you do. You just feel like, I don't know anything.
I think 87% of the first time people.
Yeah.
87%.
That's a lot.
That's a lot.
Yeah.
Yeah, I looked before I took that.
It's like 76% pass rate.
Yeah, that's low.
And like 85 or something.
Yeah. Yeah, no, I know.
See what they're saying there.
Yeah, it's,
How did he call?
giving up.
When I'm not doing things, you probably had calls. You probably.
Is it two cycles?
Like clinics or
Do
whatever.
this third one, I'm just like, I'm done. Because I do the allergy one too.
Are you doing?
No, I was due last year, and I just decided to let it go.
Well, so I'm due in 19. Good morning, yeah. I was going to
His head's there.
I've been trying to compare. So,
Oh, that's
even this option.
how long ago?
Quarterly question. Takes them down. Got every journal. It's kind of really nice.
Couple of journals.
I have so many journals I can't even read.
I'm afraid it's going to so much.
One half clinic a week now?
75. Yeah. Threw it in the trash.
Which CVID have you taken?
None of them.
Oh, okay.
Oh, is it?
My boards are paid for. So I don't need to do it again.
Hearing some of the talk this weekend.
You stayed for the whole game. I know.
Oh, yeah.
I got to see it because when your sister left, she couldn't stand those.
No, she was, Teddy was going to go back with my other sister, Judy, anyway, so that was the plan. So.
Oh, okay.
Yeah.
all
Patrick
just
read it
said
that they
no.
couldn't stand
Said,
the
"You
mess
understand
that they were getting beaten.
Well, Judy did hardly win anything
Started
at all. In
revolution.
fact, I don't think she did. My sister, who's a Husky fan,
Well, Teddy's,
Well, she was on the boat.
right? She never planned on going. Just hanging out.
that's why I want to like the board.
No, it worked out great. They got.
I'll be honest, I
I
checked
wanted
it
to
out.
go in for a little while.
Well, now you may
Yeah, they sent me a thing saying, oh, you didn't go last year.
Yeah,
The weather's decent.
yeah, we had upwards of 30 people. Oh, really? Total. Not, maybe not all the time.
Yeah, but not all of
Before
it.
the game,
Yeah, and I'm like, I think
halftime, and after.
You take
Yeah,
that one
so
together.
I was gonna just give them all.
There's only one more.
Every game.
90% of this.
So two more.
Stanford,
I know. I'm like,
or excuse me,
good morning.
USC.
Thank you.
I didn't want to fail it.
Well, you wouldn't.
They could, but they got one game at a time.
Good morning.
How you doing?
I'm good. How are you?
Serious?
Yes, Utah's nationally ranked. WSU is undefeated in conference.
It's exhausting.
Yeah,
Well,
they'll
because
be
the North
national.
was out of conference this weekend, and it was just,
No, they've got some competition. USC's coming out strong. Actually, they started our season.
but it's just,
They lost the first couple games. They played Alabama.
do another stuff. Not do my own stuff.
They played Alabama, so they had a tough game.
Catch up on your laundry and your housework.
So, no, we've got a tough schedule.
What's the best bowl game?
Oh, they get BCS. They're in the BCS right now. They're in the top 14. But they have to win all these games. They can't.
It's just hard.
Play Old Colorado.
Especially staying down there. You know what I mean? Like if you're a local person, it's like, oh. But yeah.
I'll never see a CVID.
Oh, common bear.
Yeah.
I was thinking, I had a couple.
Since they have a specialty, I haven't died in Chicago with the diagnosis. So you need to do a prescription from IVIG, and I did, and I said, I don't see it very often. Probably should really come over here to the university to get through in that, on the adult patients. And I actually intentionally sent them, called them in.
Yeah, so the CVID is
Chest and feet.
Yeah, no, I don't feel thrown the stone. Most of them, a couple of them are already.
Like yesterday, this is not related. Woman walked in and just wrote down hereditary angioedema. I said, most people will write that down. They know already what's wrong.
This is so many times around the schedule.
Okay, there's certain.
So like literally,
Yeah, and then Christmas we're here. Yeah, we had a big
there's really no way. Like, I don't know.
It's pretty warm in there too.
then I think we'll go back. If we just stay like 1 week in the countryside and just do that public fellowship. But I love
Actually, one of the more idiopathic angioedema had been put on.
but we're not going to the summer. Maybe next year. Maybe next year in the fall. Scott, I can go.
There's
Yeah, I think
It's not that long.
they've never really traveled.
Huge, super easy. Wasn't like
Yeah.
My brother-in-law would just.
Well,
I know, so it would just be a highlight. I think
keep it your house.
it's too hot. So we did partially tonight, but it was, I'm telling you, it was 100 degrees. So the crazy part was very warm, hot, and then the next day,
I come across a bridge, that's a big $10.
22 minutes to get to Everett. You gotta keep thinking it's worth it.
It's not the worst part of getting off by morning and trying to keep my biggest jerks in trailer trucks. You know, and you're like, you're not just vacation. I don't put enough day.
My heart rate goes up.
I always seem to get the guys that match you, you know. The weather's good, it's not bad, but
Let's go ahead and get started. For those who aren't up to date on the schedule changes, this is not Ron's side.
I mean, it's been a better
I had to change the date for Ron, so he's coming up November 15th. And Jake very kindly changed dates and moved his talk up. So Simon will be coming up here on November 15th. Word of the day is deficiency. The only other comment I had, I went part of the meeting over this weekend. It was a very good meeting. And in particular, I thought Drew's talk was fantastic. I didn't mention this until right now. I'm going to recommend Drew should probably do it as medical grand round. You guys are probably getting as many or more consults already that you want. Drew mentioned 5 in a day, which is a lot of work for fellows who are answering those consults. You'll probably generate even more because it was really an outstanding presentation of the coordination that the Allergy division now has with basically the rest of medicine here with cystic fibrosis people, ENT, and really educating the house staff about inappropriate diagnosis of penicillin allergy and the money that's being saved from inappropriate antibiotic use. So it would really be a generally good education for the medical house staff. I'm sure
Your check's in the mail, brother.
You'll be happy to have to give another talk. All right, anyway, my idea for this talk was not necessarily that we were going to have 2 immunodeficiency presentations back to back, but that turned out pretty well. And I thought that this is really the most common, the one that most of us in the room are internists, the one that we would most likely see in our careers, because the rest of the esoteric talks that we generally have about immunodeficiency are elegant, but things that most of us never see in the real world. So let's go ahead with CVID.
All right, word of the day is deficiency. See a lot of new faces. I hope knew you were showing up for me. So if you don't know me, I'm Jake Lenington. I'm one of the Allergy Immunology Fellows here at the University of Washington. As Dr. Altman started, I'm going to talk about CVID and then primarily talk about kind of what has been added to the kind of diagnostic criteria that came out in the last few years from where it was in 1999. That'll be the beginning of the talk, and then I'll move into what the additions are into that, is specifically how clinical manifestations and B-cell immunophenotyping were added into that diagnostic criteria. I'll review what known monogenic mutations result in CVID, discuss why it's likely a polygenic multifactorial disease, and discuss and when select patients you have with CVID to consider just sending genetic testing. A little bit of background on CVID. This is not new for this audience, but just as a recap, it is the most frequent symptomatic primary immunodeficiency in adults with an incidence somewhere between 1 in 10,000 to 1 in 50,000. Reoccurrent bacterial infections of the respiratory tract are the hallmark of the disease, though there is an increased likelihood of autoimmune disorders, malignancies, granulomatous disease, multiple other issues that we'll get into, and again likely represents a heterogeneous group of polygenic disorders. So this was the original diagnostic criteria for CVID. Not something that you need to memorize or take into too much depth. Really just highlighting how brief it really was. Specifically looking at what they think of probable CVID is almost exclusively based on what your immunoglobulin levels are doing, how you respond to vaccines, and that you can't identify some other primary immune deficiency that could account for what you're seeing, and that's your diagnostic criteria for CVID. So it's brief and definitely needs more to it. So in 2013, this group released an updated version, which is on the right there, and kind of purposely small enough that you can't read it and try and kind of take it in, just because I want you to know the highlights that it did incorporate clinical, laboratory, and histologic features, and even provided a treatment algorithm. And then the next year, the European Society of Immunodeficiency released their diagnostic criteria, and this is what I find to be most helpful. And as you can see right off the bat, I've even kind of shrunk this down for the highlights. It's much bigger than the previous ones, with a lot of new stuff included. So what is new? They've added kind of clinical correlation, not just laboratory findings. So are these people having repeat infections? But if not, are they having these other manifestations? Autoimmune disease, granulomatous disease, etc. So adds that component into it. And as well, they've put new laboratory assessment, B-cell immunophenotyping, that can be used as an alternative in patients to diagnose CVID rather than just for antibody responses. So kind of to highlight this, a couple cohorts kind of simply put on the right side there by the ESID, 900 CVID patients. You can kind of right away see that pneumonia, autoimmunity, splenomegaly, malignancy are present in any one of those in about a quarter of your CVID patients, with pneumonia being the most. And then the New York cohort just shows there's plenty of other things that do exist in this patient population that are above a general incidence of the general population. It looks like this is a little malformed. All right, and this is just another way of representing that, just showing you how many different systems and body parts are affected with infections on the right there, at the left, and then inflammatory and autoimmune diseases on the right. Let's just kind of go into these a little bit more each individually. So Up to Date actually has a pretty great table that breaks down all the CVIDs kind of infections that have been published, or at least infections of CVID patients. The highlight is right there at the top. As you all know, reoccurrent bactericidal pulmonary infections are kind of a must when you're thinking about this patient population, but they're not the only thing that you can see. And I just drew specific attention to chronic diarrhea secondary to Giardia. I've seen 2 patients in my first year of fellowship that had chronic GI issues, which, as we'll discuss, can be a result of a lot of things. That these patients in particular were having diarrhea with a little bit of abdominal cramping. And we'll see that there's a lot of things that could be attributed to, but the easiest and simplest way was just to do an infectious screen, and indeed those two patients had chronic Giardia. So kind of a simple thing to check before looking more in depth. Busy slide. I'm just going to draw your attention to a few things in it. Looking at clinical manifestations, specifically pulmonary diseases. First and foremost, chronic lung disease is historically the leading cause of death in CVID patients, and roughly a third of patients have chronic lung disease of some form at the time of their diagnosis of CVID. Obstructive is the other thing I'd like to draw your attention to. This is what you see in most of the CVID patients. They may have asthma. They often have bronchiectasis, which is kind of something we commonly think of with CVID patients, which is thought to result from recurrent infections, but also there seems to be another kind of unregulated inflammation that results in bronchiectasis. I think I've seen several patients where they may newly have been diagnosed with CVID, didn't really start having a lot of infection problems until a couple of years before their diagnosis, and not enough history to suggest that they should already have CT imaging evidence of bronchiectasis, yet they do. So there's an alternate kind of inflammatory process going on there. And then granulomatous disease, specifically granulomatous lymphocytic interstitial lung disease, GLILD, is kind of popping up more in the literature. Granulomatous disease we'll also go into more in a couple other slides. When found in the lung is usually going to be found in other areas of the body. Go into that a little bit more. Gastrointestinal disease manifestations. This is present in 10 to 20% of CVID patients. And kind of on all these slides, the clinical manifestations, going through each problem, I say may be the presenting disorder. So any one of these kind of comorbidities is not something where you have CVID, you classically think of they have infections, that's how they came to your attention. Rather, any one of these issues I discussed could be the presenting problem prior to the development of infections. Most commonly reported symptoms, diarrhea, then malabsorption, and weight loss. And the specific disorders that you can see in the gastrointestinal system, I've listed what's been associated with CVID and then just highlighted two in particular. So inflammatory bowel disease, like illnesses, can be seen in CVID. It's something that's seen in a lot of primary immune deficiencies. And when I see it in a CVID patient, this is one where I start to think, is there another etiology that we maybe could hone in on a little bit further, dig a little more deeply. And then nodular lymphoid hyperplasia. This is another one of those etiologies where I was discussing I had those patients with chronic diarrhea. This is an etiology where you can see that and diagnose it via scope. And this is what it actually looks like. Up to date has a nice picture of it. Yeah. Autoimmune disease. This can be seen in roughly 25% of CVID patients, and this often does precede infections in a select number of patients. The most frequent manifestation of autoimmune conditions in CVID is the autoimmune cytopenias. And then the kind of highlight got altered here on transition to the PowerPoint, but then a lot of patients also have this autoimmune thyroiditis, or you'll see several people who already have just hypothyroidism. This slide is just, I found interesting and wanted to pop it in there, where the authors showed kind of their thought process on multiple steps in B-cell development, where you could have a breakdown that would lead to autoimmunity. And more specifically, I wanted to just show you this, in particular, cell line at the end of the pathway there. It's CD21 low. We're going to come back to this, but this cell in particular seems to have a high association with autoimmunity and CVID.
What is the pointer on there? Is that working?
Trying to get it to work. Let me see it pop up. There we go. Right here at the end of the pathway. And this is thought, most currently is thought to be a cell type that develops out of the memory B cell after having repeat stimulation. So we'll come back to that. Granulomatous inflammation, we touched on this with lung disease, estimated to be in 8 to 20% of CVID patients. The true incidence is unknown because people could often not kind of go after it and biopsy to find it. But can be seen not only in the lungs and the intestine, which we've touched on, but can be seen in most areas of the body. The exact kind of etiology as to why this happened is not fully known. Malignancy. Malignancy is certainly a concern in CVID patients. The most common malignancy in CVID is non-Hodgkin lymphoma, and it's worth warning your patients, as is with all these comorbidities, that these are things that could develop and to watch for, but to let them know that they are at an increased, roughly 2 to 8% risk of developing non-Hodgkin lymphoma compared to the general population. And then gastric cancer has been associated with CVID in the past. There is some conflicting kind of knowledge as to whether it really is dramatically increased in the CVID population. The original kind of studies that said that were also in patients that had various infections that caused kind of chronic gastritis, which is also associated with gastric cancer. So it's kind of tough to say in that case what was really leading to it. And these are just some interesting additional clinical manifestations. The allergic disease or atopic conditions in general has always been something that's been interesting to me in the CVID patients. Often see people that have no IgE at all, classic hypogam, and they've seen an allergist for allergic rhinitis, or they've always had allergic asthma, and now they have no IgE. You can do serum-specific testing for IgE, skin prick testing that's all negative, yet they're having symptoms and responding to medication. There's even a review study that shows just that, completely negative IgE testing in patients that have what was previously allergic asthma, yet when they put them in a aero chamber and challenged them to a specific allergen, they did have kind of bronchoconstriction. So don't fully understand that relationship and what's happening there. And then the lymphadenopathy, splenomegaly, can be seen in CVID, and splenomegaly is as high as 26% in CVID patients. There's certainly contributions from the granulomatous disease, but cannot fully explain the etiology behind those. And liver disease, roughly 10% of people have liver dysfunction. That's attributed to many factors that can be seen in CVID. There's multiple infections, granulomatous disease, there's other lymphoid hyperplasia conditions that can be seen that lead to that. And a lot of people say that alk phosphatase can be kind of an important parameter to monitor for evidence of liver disease, and not just the other stuff that we always think of, like LFTs and bilirubins. All right, so I think we can say from that and how prevalent these conditions are that they warrant being in the diagnostic criteria, which then leads us to our other new addition, which is the result of B-cell immunophenotyping. Specifically, what made it into the diagnostic criteria is low switched memory B cells. So we'll go a little bit into depth as to where that recommendation came from and how it plays into things. So 3 studies really led to that addition, and that's the Freeburg classification in 2002, followed by the Paris classification in 2003, and finally with kind of a capstone study with the Euroblast trial in 2008. And before I launch into kind of a brief review of these studies, their original goal was to do B-cell immunophenotyping on CVID patients and see if they could find kind of an algorithm that, based on those laboratory studies, that you could nicely put CVID patients into and have kind of their own diagnostic criteria just based on that. But as they found through the study, CVID is something you can't just say it all fits nicely into a box. So that didn't pan out, but they did find some interesting findings we'll go into. And I mention that just because some of their Breakdowns are a little bit complicated, but we'll kind of try and focus on the important details. All right, so the first study, the Freeburg classification, 2002, they broke, and before I go too much farther, in case anyone isn't familiar with B-cell immunophenotyping, essentially it's a flow study, and you take peripheral blood cells, and then you label certain markers on B cells after you've selected them out. From that, you run flow, and you can say how much of each type of B cell development is present in the patient to know if they're deficient or have appropriate distribution of their B cell development. So they broke down into two groups. Group 2 is normal numbers of switched memory B cells, and group 1 is reduced numbers of switched memory B cells compared to a normal control. And that's right here on the slide where I have this kind of red dot. This is the highlight and the important part of the finding. The most important part is that 77% of the CVID patients in this cohort had decreased switched memory B cells compared to normal healthy controls. They also did divide this group into two subgroups. Group 1A is a group that had an increased number of the CD21 low cells, which means that the CD21, which is part of the complex with the B cell receptor, is less present on the cells, but there's more of those cells. And they called this immature at the time in 2002, but as we should saw on that last slide, that this is actually coming from a memory B cell. Why that's relevant? In that specific group with an expanded CD21 low population, every patient had splenomegaly, and there was also 6 out of the 10 patients with that finding that had autoimmune cytopenias, which is higher than the other group. So an association is kind of started to question there, does this CD21 low have specific things, comorbidities that can be predicted based on that finding? This is followed by the Paris classification 2003, which labeled their groups differently, MBO, MB1, MB2. That's not really important. What is important is that they too found that 73% of their CVID patient cohort had decreased switch memory B cells. So that's represented with the MBO group is decreased memory B cells across the board, switched or non-switched. And then MB1 is just decreased switched memory B cells, but resulting in a total of 73% not having decreased switched memory B cells. Not every patient in their cohort had the CD21 marker done. That was not the point of their study, but they did put back in as many patients as that had been done on after the Freeburg classification came out, and they did not see the same association with splenomegaly and cytopenias. But then came the Euroclass trial in 2008, which is a much larger study. It was a multi-center study in Europe that had 303 CVID patients, and they too tried to kind of make up their own classification, and then they also reassessed their patients in both the Paris and Freeburg classification system. And it's just a breakdown of their patient population, close to similar distribution in men and women, and age of onset and age of diagnosis in the 30s, plus or minus 20 years, and then a reasonable breakdown of these other comorbidities. From their cohort of 303 patients, they dropped 10% of them because their B cells were less than 1% of the total lymphocyte population. They dropped those patients because, one, it would have been really hard to do the flow on them, and then two, there probably was a different diagnosis that just hadn't been made if you have that few B cells, whether it's XLA, hyper-IgM, or something otherwise. So of their other 90%, the key finding is 80% of them showed reduced numbers of class switch memory B cells. So across the board of these three studies, we're seeing approximately mid-70s, 70% of the CVID patients had decreased switch memory B cells, and that's what made it into the diagnostic criteria of CVID. Additional findings from this study, in the patient population that had less than 2% switch memory B cells, which they kind of refer to as a severe reduction in these cell types, they found decreased, significantly lower serum IgG and IgA, which could be expected just thinking of having low B cells. And then they also found a higher incidence of splenomegaly and granulomatous disease. Further, if you have these low switch memory B cells and your transitional B cell population was increased, this was associated with lymphadenopathy. And then their evaluation of CD21 low, whether it has an association with anything in particular, they found it did. It was significantly associated with splenomegaly in the presence of granulomatous disease.
When you say switch, you mean switch to make a specific isotype?
Yeah, so in the B cell phenotyping, not only do they kind of see all the progression of B cell development, but they also check the ability, can a cell switch from IgM to IgG, IgA, does it have that capability?
So
that's
do they fail to switch at different points? Some people can make M but not G, but not A.
Yeah, in the experience I've had is patients will have IgM and then they would switch to IgG and IgA, which is usually what's checked, and so you can find somebody that'll have a CVID or have a cell that can make IgM but is not able to make IgG and IgA. And there is some patients, if you checked it annually, you can see, say, IgA drops off, they no longer are able to make that, and then the next year IgG drops off, they're no longer able to make that. So it can kind of progressively break down on their ability to get to that stage of development.
One more question. Do you ever see these people with normal IgA if their IgG levels are that low? Is that a mutation that's possible?
Mechanistically, it's hard to explain, but I think I have seen a couple where that is the interpretation. But you also have to take it with a grain of salt because you're just sampling the peripheral blood cells on that day. You can't say what's actually happening in the lymph node or what's happening in the bone marrow. Where you're just getting that sample of the blood on that day. So I have seen that. It's not a common thing, but it can happen.
Just in a practical sense, you've started a clinic here, haven't you, for adult CVID patients?
Not an official clinic at this point. We're hoping to bring Suzanne over at some point. Multidisciplinary, but no, we haven't started that yet.
But how many patients do you have, adults?
We probably have people on IVIG or sub-Q, probably 50 or 60. I'm guessing.
So this far and away is the most common immunodeficiency disease. It's interesting. You just struck me in the beginning. 1 in 10,000, 1 in 50,000 is more common than HAE, about which we, appropriately make a big deal and have all kinds of new therapies costing $1 million a year. Just to put it in perspective, that this is a relatively common disease.
Confusing table, but just wade through the details. What this is on the right, the Paris classification scheme, on the left, the Freeburg classification scheme, and then this is actually coming from the Euro class. They put their cohorts back through both the previous algorithms to see where they would land and what associations could be made. And they did find, if you look on the Freeburg scheme, that the patients that had low decreased switched memory B cells and also had an expanded population of the CD21 low, that there indeed was a statistical difference in the presence of splenomegaly and granulomatous disease. And in the Paris classification, that association was also seen, but it was seen in the population that had low total B cells, switched or non-switched.
Just out of curiosity, all three of these studies European?
Yes.
What's wrong with the Americans?
Waiting for Drew.
in the Euroclass, this is the first half of their schematic on how to differentiate these people. Again, just the highlights are that, like pointing here, this is the severely reduced switch memory B cell population, and in that group, they found the same, that there was a significant increase in splenomegaly and granulomatous disease. And then over here, if you have that cell or that patient with decreased switch memory B cells and their transitional B cells are expanded, there's an increase in the presence of lymphadenopathy. The second half of their schematic gives a relatively interesting finding. Whether you're looking at severely reduced class-switched memory B cell population or those that aren't severely reduced, that irregardless, CD21 low, having a higher proportion of those cells, there's a higher association with splenomegaly and granulomatous disease. So kind of showing that CD21 low is its own risk factor for those etiologies rather than just being severely reduced in your switched memory B cells alone.
Could you mention how did they determine splenomegaly? Is it ultrasound or just physical exam? Do you know?
It's not the details and the methods of that were not completely described in how they were determined. I'm imagining they had it from previous imaging and their charts. This is kind of plug and play from the European Society of Immunodeficiency CVID cohort.
Okay, a naive question. So the people who have normal switch B cells, you'd think they could make all the isotypes. Why do they still have this disease?
I think, well, that's what we're going to talk about right now.
Okay.
Good question.
What about the group with developed non-Hodgkin's lymphoma? They looked at them in this regard to see if they have particularly that group that had the increase in lymphadenopathy. Are they at increased risk?
I did not see that association really discussed or any conclusions drawn to that. In these three studies, there has been a couple more that have come out since this, but I didn't include them. I don't know if anyone's looked at that in particular. Okay, so the variability of common variable immune deficiency. CVID seems to certainly be an umbrella diagnosis covering several genetic subtypes that we'll kind of review. And we'll see that there's several genetic etiologies that cause their own, have essentially their own unique kind of disease, or should have their own unique disease based on having specific genetic mutations, but that they result in a clinical phenotype that really is blurry and best fits with CVID, so that's how they were initially diagnosed, and then later, after having genetic testing, found that they have kind of a unique etiology to themselves. To do this, I want to do a couple things here. One, just a quick, simplistic view of B cell progression and development, and then review this great article that came out this year in Immunogenetics by Bogert. That reviews what kind of known monogenic diseases exist that have been called CVID in the past and are now known to be their own genetic etiology. But by doing so, I hope to highlight that any breakdown in these specific intricate processes doesn't give you a very fine clinical phenotype. They're very blurred because they're so interconnected, and will result in a picture that can look like CVID depending on how it's being manifested. This depiction of B cell development in itself, it's really complicated. Would probably be a few chapters in an immunology textbook. But there's multiple steps within this process that if there's breakdown, you have a primary immune deficiency. And there's some that are very well characterized in this process that are well-known diseases in their own right. However, if you have a hypomorphic mutation in any one of these four that are kind of well-known, you don't get that classic disease. You get kind of a blurred manifestation. And so each one of these has been diseases that have been diagnosed as CVID and then had genetic testing and found that they have a hypomorphic mutation. It doesn't completely knock out the protein and allows some development of the B cells and results in a picture similar to CVID. And kind of go to back to this slide. Most of the mutations that have been found at this point for CVID, my highlighter to work, are going to be found right essentially in this step where the interaction with this T cell and then just internally what goes on with the B cell or a T cell to allow this process to work. So that's what's represented here. Just kind of a softly take this in. Each one of these purple spots on here represents a protein that has a known monogenic or biallelic mutation that, if that occurs, can result in a clinical phenotype that looks like CVID. In fact, every mutation on here has been reported in the literature as a patient initially diagnosed as CVID, then genetic testing was done and found to have their own kind of unique etiology. This slide in itself, if you look at the complexity of how this all works, you can imagine that if one of these things goes wrong, it sends the whole thing a little bit haywire, but there's multiple redundancies built in. So if one thing goes wrong, another, say like this goes wrong, there's other pathways that converge with the same end product. So it's not always going to be the same. For instance, if a patient has a mutation here and a mutation here that's not picked up, or over here, this patient's going to look a lot different than a patient that only has a mutation here. Or if for some reason they have a better functioning system in this pathway than is normally thought, you can have something different. So it just highlights how interconnected things are and why you can come up with such blurry clinical phenotypes and a mishmash that kind of results in CVID in a lot of cases, or what looks like CVID. So in this review, they broke down what has kind of been reported in this situation, the monogenic mutations that have been found. So all of these have been found and able to cause a clinical spectrum that looks like CVID. Again, we'll not run you through all of these, but I do want to walk through those three most common ones that are listed there that have a bigger piece of the pie. PIK3CD, LRBA, and CTLA4 deficiency. Not so that you memorize the disease, but can kind of see, again, how easily it is to have a blurred phenotype and make it so challenging. So if you draw your attention to my big red star, we look at this area of this interaction. There's CTLA4, there's LRBA, we see how they're interconnected. CTLA4 is on the surface here. It's trying to interact with CD80 and 86, and it's in competition with CD28. So LRBA is actually a lipopolysaccharide responsive phage-like anchor protein. It's located in intracellular. It's involved with multiple cell processes, including endocytosed vesicles and lysosomes. Its function is to traffic these vesicles. It's involved in cell death and regulation of cell survival. CTLA4 is the cytotoxic T lymphocyte-associated protein. It's actually an inhibitory T cell receptor, constitutively active in T regulatory cells, but upregulated in conventional T cells after they're activated. Its purpose is to compete with CD28 for binding to CD80 and 86, and to do so will prevent excessive T cell activation and helps promote immune tolerance. And LRBA has recently been found to actually pull CTLA out of lysosomes where it was going to be destroyed, puts it back on the surface so that it can, again, help to kind of not let a T cell get overactivated and help with tolerance. So they're very interconnected. If you have a mutation in either one of these, the clinical presentation as well as laboratory findings can be incredibly variable. As I mentioned, there's been folks diagnosed with both of these as CVID and then found to have a mutation later in one of these and are now considered their own separate diseases from CVID. LRBA deficiency specifically is a loss of function mutation. It's a biallelic mutation that, when present, makes the protein absent, non-functional. It has an autosomal recessive inheritance, will typically develop in infancy to childhood, and is highlighted by severe lymphoproliferative disease and autoimmune disease is present in most patients in early, but they can also have polyneuropathy, enteropathy, infections, increased risk of lymphoma, and some folks can even have a disease that looks a little bit more like a combined T and B cell defect. The laboratory studies are very variable. You can have classic hypogammaglobulinemia across all subtypes, or you can have very normal-looking antibodies, or one low, rest fine. As is the functional antibody responses are also very variable. It does seem that most of the patients have at least one consistent feature of decreased switch memory B cells. LRBA, CTLA-4, somewhat similar in what you actually see clinically, but as far as genetically, it's a loss of function mutation, typically heterozygous, resulting in a haploinsufficiency. It's autosomal dominant with variable penetrance. The onset of development of having symptoms can be anywhere from infancy all the way into adulthood. And then clinically, it looks very similar to LRBA, as you can imagine, since they kind of are going hand in hand, but has autoimmunity, recurrent infections, benign lymphoproliferation. So you can imagine if certain features of this disease are popping out, it's going to look just like CVID. And very variable lab findings as well. The last one I'll put you through is PI3K. You can see that it's present in intracellular and cellular pathways in both the T cell and the B cell. It is actually phosphatidylinositol 3 kinase, crucial cell signaling molecule downstream of multiple B and T cell receptors, maintaining the cellular homeostasis. There's now known mutations that result in overactivity and deficiency that now have their own disease classification. If you have an overactive mutation, it's a gain of function mutation. It's a heterozygous, and it essentially allows the catalytic subunit of this protein to just be constitutively active, so having an overactive signaling pathway. It's autosomal dominant. This presents typically in infancy to early childhood, and what it can manifest clinically like is very variable. It can look just like CVID. It can look like a combined immune deficiency. It can look like hyper-IgM. And this is somewhat reflected in its laboratory features, which are variable defects, numerous that can be present in both B and T cells. But one thing that seems to be uniform, or in most patients, is that the IgM will either be normal or elevated, as will they also have decreased memory B cells. And the alternative PI3K deficiency, while a loss of function, also heterozygous, is actually in the subunit that controls the catalytic kind of part of this protein. So essentially results in hyperactivity in the same clinical spectrum that we just talked about. So it's kind of going through those. The purpose is just showing you how variable and different any one of those mutations can be and resulting in something that looks like CVID, just highlighting the complexity that does exist with CVID and why it is such a hard thing to fully understand. And the authors kind of highlight a lot of what I've been trying to get across, that CVID is not just a result of monogenic mutations, but rather likely a polygenic and multifactorial disease. Based on these following 5 points, one, that 10 to 30% of patients are not found to have any pathogenic mutation. There's a large phenotypic variability between patients with the same primary genotype. Presence of variants in asymptomatic relatives and or the general population. Why can you see a patient, you find a genetic mutation that looks just like CVID or something or other, and then you check their sister and they have the same mutation but no disease that you can speak of. Sporadic occurrence in about 90% of cases, and delayed disease onset in many patients. So there seems to be modifying factors. Which of the CVID patients should you consider genetic evaluation on? There's been a lot of papers that have come out in the last few years that have showed various techniques on next generation sequencing on how you can do this process. I don't think that's too relevant, but there has been a few, like Mafusi, who published this year on their CVID cohort, in which they selected 50 patients from to do genetic screening from and see how many genetic etiologies they can put to their CVID patient population. They picked patients out of their cohort based on 4 factors. Did they have early onset manifestations? Did they have autoimmune/inflammatory manifestations, low B-cell lymphocyte counts, or a family history of hypogammaglobulinemia? The purpose of this slide is really to get to the end result that's highlighted in the upper right corner, but what they did is whole exome sequencing in their patients. From that, they filtered it against 269 primary immune deficiency genes that are known. From there, they did a little bit more technical work to decide whether these are disease-causing mutations, confirmed them with Sanger sequencing and functional studies if needed. From all of that work, they were able to find 11 monoallelic disease-causing mutations and 6 biallelic variants. So this results in, all this work results in 17 probable disease-causing mutations in 15 of the 50 CVID patients they looked at, which is an end result of 30% of their CVID patients. They were able to find a genetic mutation that could account for their clinical phenotype. And this is what they found. And you can see kind of on the side here that they actually have all the ones that we just discussed: PIK3CD, LRBA, CTLA4. So that does happen. And from this, just general conclusions, that our knowledge of CVID is expanding, becoming more complex, likely reflecting that CVID is a polygenic multifactorial disease. We know that the hallmark of this disease has been recurrent pulmonary infections, but there are several other clinical manifestations. B-cell immunophenotyping by flow cytometry can be a useful tool in some CVID patients in diagnostic purposes, and may eventually be able to develop or predict possible comorbidities. And the next generation sequencing is becoming a reasonable tool to evaluate select CVID patients.
Are you using like response to phage still in clinic? And in some of these sort of equivocal cases, in other words, like their IgGs like 450 or 500?
Over the last year we haven't, but that is not because the test isn't useful. It's just that they had to reprocess through the FDA our allowance to use it. So I think they just got clearance and are going to restart using phage testing.
Now that they have some of these gene splicing things, has anybody tried to take these cells with no defect and splice the gene back in for the defect to see if that corrects the problem?
Gene therapy?
Yeah.
For CVID, I don't know if that's been attempted. There's a lot of work in multiple centers for select primary immune deficiencies. I think the folks here are working on like hyper-IgM. UCLA is working on chronic granulomatous disease, and they're actually enrolling patients. But for the CVID, don't believe that I know of people doing G repair.
What would account for the change in what they make if they stop making IgG and then stop making IgM? It's not genetic because that would have been constant throughout, but what would account for that change? You mentioned that it's you can follow a patient and they over time, but that happens.
It's kind of tough to understand or even explain, but it seems like in a lot of CVID patients that it's once that everyone presents a little bit different, but there certainly seems to be a progression of many CVID patients where you'll find one not only clinical feature but laboratory feature, and that over time, if you follow them, they just continually to progress and become more problematic. So if you're going through your isotype switching to MGA, etc., that as your disease progressively gets worse, you can switch to less or fewer and fewer until you're not switching at all, and then you just have kind of complete loss of switch memory B cells, and it seems to become problematic. But that's only one pattern of CVID patients. They're all kind of a unique beast, and so that's something I've seen, but not in every patient.
Art Bay typed in a question here. He discussed granulomatous lymphocytic interstitial lung disease in more detail.
There is kind of, for instance, nodular lymphoid hyperplasia is something that can be seen diffusely throughout the body and can be seen in the lungs, and when it is seen in the lungs, it's seen in other areas like the liver, spleen. And we actually saw a patient earlier this year with nodular lymphoid hyperplasia, a woman in her 40s who came to us who had had a family history of lymphoma and recently started having infections that led to imaging of the chest as well as the rest of the body, and found kind of these large lymphoid-looking collections of cells throughout not only the lungs but the body, and was very concerned, given her family history of malignancy, that is what she was having, and that could explain why she was so kind of run down and having infections. That got biopsied through the chest was biopsied, and the cytology or the pathology showed nodular lymphoid hyperplasia. Despite that finding, she kept getting continually worked up for malignancy. Had a second biopsy that was sent to Mayo and said, this nodular lymphoid hyperplasia can be a manifestation of CVID. Consider this as an alternate etiology. That's how she came to us. And Dr. Torgerson saw her and felt that was just a representation of whatever mutations resulted in her CVID phenotype. And then that particular pathology is actually a collection of B cells that are causing that problem, surrounded by T cells and kind of almost forming like a germinal center. And that is treated completely different. It's not overly hard to treat. So if you have a CVID patient that's already on IVIG but having kind of bulking issues from nodular lymphoid hyperplasia, you can actually retux them and wipe out all the B cells and give them azathioprine to address the T cells and kind of melt those lesions away.
Can you go back to that exceedingly complex diagram, the one that shows B cells and T cells talking to each other? So I get the main point here that innumerable monogenic problems can lead to the relatively same clinical picture. But it's still very confusing exactly how these two cells are cross-talking to one another and how those little how those defects turn out to cause a clinical syndrome that looks much the same, especially the one where you can have either gain of function or lack of function and still come out with the same disease seems intuitively wrong. Can you say more about that?
I don't know if I have anything more enlightening than what I've said. It's essentially you have this amazing interconnected web of processes that are working perfectly to kind of give you a functioning immune system it's built in with multiple redundancies. So if you have a breakdown in one, hopefully the rest can pick up the slack and not completely shut down on you. But I think in various stages of the immune, or in the various stages of how dysfunctional this process can get from a single mutation, if it's by itself, maybe you get a little bit of an incomplete functioning immune system. There's just a little bit of hypogam, or that can get a little bit worse and become very bad CVID or even worse. Or it can just not be functioning properly and become an overactive immune system and give you your autoimmunity. I think it's just so interconnected with so much potential to be modified by other areas that you just get blurry phenotypes.
I guess the main take-home message to me is that these people are complex enough. They probably should really be in a specialty clinic where all the manifestations are looked at and not just give them IVIG and assume you make them better.
Yeah, I think it's a good reminder that once you've diagnosed a CVID patient, have them on IgG, protecting them from infections. You're just doing that, you're protecting them from infections, but they do have an increased association with all those other things that we've discussed. And this would be a reasonable thought process of monitoring, or at least informing the patient that these are other possibilities and to be aware of them.
I had a guy move from Chicago and just told me he had this diagnosis, and he said to me, just write the order for my IVIG and I'll be a happy camper. And so I did that. And then he never came back. I told him you should get a chest CT, among other things. And then I finally called him in and just said, I'm not the right doctor for you. I don't see enough of this disease. This is more complex than just getting IVIG. And I sent him over here for Drew and others to take care of, because I just realized, I don't know enough about treating these people. It's too complex.
Jake, when you first talked, you said the New York cohort in the ESID group, the ESID people had 23% malignancy, and then the New York group, they didn't even comment on malignancy as a side effect of this disease. And did that ever, is there a big difference between these two, or is that just the size of the study, do you think? It's like your 10th slide or something like that.
Yeah, I can get other people to see it as well. That table actually didn't come in as well.
That one.
It's kind of cut off. It actually is down at the bottom. It's for some reason not translating in this PowerPoint. I don't know how it got modified.
Okay.
But you can actually see on the very bottom where it's covered up by these. There's lymphoma, and I believe there's another malignancy right underneath it. Lymphoma was 8%. I can escape out of this.
So there is a malignant component to the New York group as well.
Yeah. So lymphoma was 8, and other cancers were 7.
Okay. That explains it.
Another great review. So in the outpatient world, in the community rather, we have some patients who already started IgG replacement therapy, and can you see any reason why they shouldn't get B-cell phenotyping once they're on therapy? I don't see any reason why they should.
They could if they needed it. It doesn't affect that at all, which is the kind of the benefit over like vaccine. Once you're on immunoglobulin, you can't check vaccine responses. So if you get someone like Dr. Altman was explaining that comes from Chicago without a lot of paperwork and just says
I have to come get you.
sure, that they have CVID and you can't prove it, and you want to do your own workup, you can't check vaccine responses unless you're willing to stop their therapy. You could check B-cell phenotyping.
I spoke a lot with Matt Altman about it because there's a lot of patients who come in who have diagnosis, but I can't really get B-cell phenotyping from the outside world very well. There's a lot of practical barriers. So like Len was mentioning, I just send them to the university for their workup and screening. We can manage, like you said, IVIG on the outside, but the rest of it's just too hard, I think.
Yeah, I think B-cell phenotyping, there's also T-cell phenotyping, but B-cell phenotyping, the genetic analysis, there's tons of barrier for your everyday allergy immunologist to be able to obtain these assessments in their patients. One is getting insurance companies to pay for it, knowing where to send it, who does a good job. Just seeing the B-cell phenotyping that comes back from Troy's lab is amazing. That you'll see kind of lesser degrees of phenotyping done in commercial laboratories and other universities that don't seem to stack up quite as well and are quite as descriptive, giving you all the information that you want. So it's certainly a barrier.
I had just kind of a comment and question, kind of flipping it the other way around, because I'm a pulmonologist, so I see people with lymphocytic interstitial pneumonitis, which is one of the 5 idiopathic interstitial pneumonias, as well as we also see other people with bronchocentric granuloma and Castleman's disease. These all have kind of lymphoid hyperplasia. So if we see someone with that, we'd often send, at least if they see me, they would get immunoglobulins and things like that sent off to kind of screen for CVID. How sensitive is that? I mean, if you say that like their total immunoglobulins are normal, do we stop there, or now that we're entering this era of immunophenotyping and genetic mutations, do we need to send those patients to be evaluated? Because, I mean, most of them don't. They just...
Yeah, hard question. I mean, it's going to be patient-specific always, but you're exactly right. You can have certain manifestations of CVID, the clinical features, develop even before someone's having a lot of infectious problems. But the labs follow the same suit. They're not always there right away when you want them. So immunoglobulins may be normal, but if you check their response to vaccines, perhaps that's less than ideal. Or if you check B-cell phenotyping and their memory B-cell population is already pretty low, that may be a clue that while you don't have low immunoglobulins yet, but your memory cells are low, that you're on the process of getting there.
Right. Yeah, oftentimes these people are like, 40, 50 years old, and we typically haven't referred them to immunology very commonly unless their immunoglobulins are low. So,
I think there is an expanding awareness that while this may not be CVID or some manifestation leading to CVID, there's possibility.
Right. Well, that's the thing. You always have someone there, and you don't really know. Well, why did they get? Or even just with bronchiectasis, we see, everyone gets exposed to bacteria. There's some reason why that, those people who we see who have bronchiectasis, are more susceptible to infection in some way. I think it's not just bad luck necessarily. So, but
it could be something that maybe needs to become a check mark, and when you're doing your workup, have we ruled that completely out?
Yeah, interesting. Because I would say we typically, the practice in the pulmonary clinic is not really to refer those people to immunology, but so interesting.
Well, thanks.
Yeah,
It's
right.
obviously very complex. My take-home message is
sort of the classical.
you probably
Right.
should not manage people just exclusively with IVIG and forget about it.
Yeah, actually one of the most,
complications.
like some high portion of people with bronchiectasis have a positive rheumatoid factor.
Yeah.
So is that just like the fact that you have autoimmune disease is part of your underlying some other immune defect?
Right. Yeah, when we see that, we always question that, because some people in the CVIDers don't, have normal or low, immunoglobulins that don't have a history of infection.
Yeah.
So do they have a cold pulmonary infection that's causing the bronchiectasis, or is the bronchiectasis a result of some other infection? Classically, it's a recurrent infection.
Yeah, exactly. Yeah, well, I've always wondered about that too. It seems like if you just have low immunoglobulins, you're like people post-transplant who have low immunoglobulins have higher bronchiectasis.
Question for you. So, we had
I was thinking the granuloma synthesis, there's like two worlds converging here.
Yeah, truly. We had one of our shot kids, she was freaked out because her PCP said that her, it was a great story, but it all started from, she had GI pain, they did an abdominal ultrasound, and the radiologist said that evidence of mild interstitial lung disease.
Thank you. I'll be checking.
Because of some ribbing from the
Well, I mean, they would need to have. The problem is that like no, you have because
No problem.
no, I mean, you would have those findings for practices. So I mean, that's the thing. You have to do a scan. You have to flip someone over to make sure that it's not just
Good job.
practices at the basis.
you know, because
Dr. Altman, we tried to do welcome calls to expedite the process. We tried to book patients yesterday,
Is that the new patient I saw yesterday?
to expedite the process, and she's not answering.